Thank you so much. So we actually have a very special guest who is going to come on up, Chuck Fada, who is a patient, a former patient here at City of Hope. And there he is. Yes, please give him a warm welcome. So we are so grateful to you, Chuck. You want to come on it this way? And this is all about the patient experience. So we just, would love to hear any, this is a wonderful group of nurses here to welcome you. And we just want to know from your experience, anything you can share. So again, thank you so much for being with us today.
I'm happy to be here to speak to you today. Actually, with everything I've been through with my cancer, my health issues, I'm very happy to be anywhere today. I'd like to tell you that I've spent many days and weeks in hospitals, and that I have a great admiration for nurses. Your knowledge, your optimism, dealing with my illnesses, the amount of time you've spent with me, your comforting care, your friendly conversation, and your concern are greatly appreciated. I'd like to share with you my CAR-T experience here at City of Hope. I hope it gives you an insight into how patients feel about their treatment. Now, the reason I had CAR-T was starting in 2014. Over a 2-year period, I had 6 rounds of chemo, a stem cell transplant. I had an operation in which they removed my spleen, the tail of my pancreas, and half my stomach. None of these treatments stopped the lymphoma. The cancer was spreading rapidly after the operation, and my doctor wanted to do radiation, but it was no longer an option. Now, for me, luckily, my doctor at USC, Dr. Ann Moorbacher, went to a conference and learned about CAR-T. She called Dr. Siddiqui here at the City of Hope and tried to get me into the program. Luckily, there was one spot open. And after I did all the testing and I qualified for it, I was in the program. For me, at this point, CAR-T seemed to be my only hope. I could really feel some of the tumors, and I knew that if this didn't work, I probably wasn't going to make it. After that, the procedure started, and I went in to have my T cells extracted. Then they were brought to the lab and engineered. And after 2 weeks, they were ready. And at this point, they had me go into the hospital for a day and do chemo. So I went in, did the day of chemo, and 2 days later, I was back in the hospital for my infusion. By this time, I was extremely weak and exhausted, but I was hopeful. And the attitude of my doctors at the hospital when I got in helped my hopefulness. I'll never forget the smile on the nurse's face when she said, "Here we go." When they infused the T cells, it was a foregone conclusion that the T cells were going to fight the cancer and it was going to work. So after 3 days after the infusion, it seemed like nothing was happening. I was doing like I always do in the hospital, just making the best of it. And of course, complaining about the food. But on the 4th day, which is a Thursday and my wife and my anniversary, things changed. I remember the nurse saying, "I think he's getting confused." And after that, it was one big blur. I was told later that a later date that I had a cytokine storm. Because of it, I don't remember much during it other than little bits of seeing people in the room and them talking to me. What I do remember is waking up, calling my wife on the phone, and her starting to cry. I asked her, "What's wrong?" She said, "Do you know what day it is?" I said, "It's Thursday." She said, "Nope, it's Monday." I was really in shock to hear that. She showed up later, gave me a hug, explained that how the nurses had taken care of me, talked to me, shaved me, and put up with me. She said I was not very cooperative. I would respond or talk, but who knew what words I would say next? It seems the filters got turned off with the cytokine storm. You know, some of my sarcasm that I come out with is only meant for my wife, not for the general public. So a little later after that, Dr. Siddiqui came in with a big smile, shaking her head at me and a sigh of relief looking at me. I was clueless of the danger I had been in. I didn't understand until after the treatment with the cytokine storm happening to me, the delicate balance the doctors and the nurses had giving me steroids and letting the T cells do their job. My wife told me she could see everybody was confident, but the decision making was stressful for everyone involved. I then remember the nurses coming in. They were happy to see me back, especially with my filters on again and me being my polite self. So a couple of days later, I was tested to see if I was physically able to go home. The nurses had me walk upstairs, checking my balance. I had been in the hospital many times before, but never wanted to go home so badly. I told them I was okay and really wasn't honest about the difficulty walking up the stairs and doing what they wanted me to do. But after 11 days, I was finally going home. You know, I was home 3 days. And on the third day, I got off the couch to walk a little bit. And that's the last thing I remembered until I woke up hours later in Huntington Hospital, not knowing where I was or how I got there. It seemed I passed out. My wife had to call an ambulance and come get me and rush me to the hospital. And the next day, the doctors at Huntington decided that I should go back to the City of Hope. There at the City of Hope, the doctor determined I was having heart trouble. Well, I knew that if I made it through the cancer, I was going to need open heart surgery and a valve replacement. If I had a lot more time, I would tell you all about the journey. But as you can see, eventually, after 2 heart operations, I'm fine. So once again, I'm back at the City of Hope, and they worked on stabilizing me. This time I was honest about how I was, and I got out in 5 days. So after that, I'm back home for a month. And it's time to find out the results of a scan they did a few days earlier. I was so weak. I lost so much weight by then that my wife had to wheel me into the hospital to see the doctor. And sitting there in her room waiting for her, I thought, as weak and as awful as I feel, I still probably have the cancer. But I was wrong. Dr. Suzuki came in the room and said I was in remission. My wife and I cried a little bit, gave each other a hug. I couldn't wait to go outside and call anyone I could and tell them that I was in remission. It was pretty amazing. You know, as I reflect on the CAR T treatment, I still don't understand how it worked. I still don't understand how I got back the life that I had before cancer. And I don't know how everything else failed in this work. But you know what? This is my miracle. And this miracle was made possible by all the incredible people that have dedicated their lives to the care and cure of cancer. I want to thank all of you here today for your part, so many people's care, and those that have gotten their miracle. There just aren't enough words or ways to say thank you. I really appreciate you letting me tell my story today. Thank you.
Really appreciate the time, and we're so glad you're here. And if you want, we are going to have just a question and answer session for some of the speakers. You're welcome to stay with us if you want to answer any questions from the group here. I'm sure. So we'll bring up May and Athena again, and you're welcome to have a seat or, okay. Thank you. Okay, so I don't know if we have anything in the chat, but does anybody here have any questions for May or Athena?
My question's for Athena. In the first case study that you mentioned with the one patient, I just was wondering what the indication was for the tocilizumab that he got. Was it solely based on the IL-6 test result that you got, or was there some other indication for it?
Well, at the time, we didn't even have the IL-6. The results that I have is after the fact that I know it went up. It was because of his symptoms. He was not improving. His liver function tests were rising, and his blurred vision was not improving. His headache with Tylenol was controllable, but he was not improving. And per the management of that protocol, it was advised to use tocilizumab when the liver function test was above, like 4 times above normal level.
Okay, so it's not based on like typical like CRS symptoms like that you would see for other type of CAR T, like the fever, hypotension. So there's like a separate protocol for tocilizumab.
Correct, and that's why. And one of the reasons I chose particularly that that case studies, they're not neon color. You know, like that particular cases, both of them were not very. They're not typical that you have fever, you have hypotension. Those are the easier one that you have right after that. These patients, as a matter of fact, this particular protocol is now not used because of the amount of toxicity it was causing, and also it was one of those quiet one that one patient died on it because patients went home. They did not. He had the blurred vision, but he did not call the doctor, thinking like, "Oh, I will call. It's cataract, perhaps. I will call my doctor later." And by the time it was the cytokine, storm was so high that it took over his body and it was not retrievable.
Anyone else have questions for here? And you can also ask Chuck questions too. I'm sure we can get him a mic, but we'll go over here first.
I think this one's for May, but I did want to thank Chuck very much for the for telling us about his journey, because that was a pleasure to hear. Thank you. May, you alluded to the caregiver fatigue, and so it was a very interesting point, and I guess to try to frame it in terms of a question, is there some balance? And if I heard correctly, can be caregiver fatigue. Potentially, family support can be more optimal because they're more embedded within the journey, perhaps. I may be reading into your comments. So I guess the question becomes, to the extent caregivers can be supportive, is there sort of ways they can be supportive, but we can also mitigate the fatigue factor? I mean, and that's a very hard question to answer, I know, but just your thoughts, sort of how do we strike that balance, particularly if we're supporting caregivers in the patient journey?
So very good question. So a lot of time, we forget to ask how the caregivers were doing. And that has been my sticking points every time I see a patient. I look at them. I give them, a support, anything that they need. And you'll be surprised. I'll be surprised actually a lot of times that the things that I didn't think about that is in their mind. So for instance, I had a patient that I saw over in day hospital. They were from out of state. The patient was very young patient. The mother came, so she obviously had to be on FMLAs. There are financial concerns, the food insecurity. I mean, a lot of little things that we don't think about. So we, as a group, day hospital nurses, APP, we think about things that we can support, right? We can refer to our social works. There are anything that we can do, little things, even was heartbreaking, mainly because it's during Christmas time that we thought about, we come together, can we assist anything, right? Any food, or sometimes we recommend certain things that you have other family member when they are in the day hospital, they might sit with the patient where the mother can go out and eat, things like that, that we have to kind of really think outside the box. So these are novel treatments come with complexities, right? A lot of things that we as a nurses, we spend more time. We see the social aspect of it. So what I call them social determinant of health, that a lot of time we have to think about these, and we need to be creative and address that. And my starting point is I always ask them how the caregiver doing. Are you taking care of them? Sometimes all they need, little thing, is that just to go home and shower, had a good sleep, things like that.
Any other questions over here?
Hi, I'm just curious, do you have any helpful tips on how to co-manage patients when they're at the time point of returning back to either their home state or their primary provider, and there may be clinical aspects that we would want them to monitor or follow up on before they return back for a study visit?
So based on my experience, a lot of our physicians has a connection with the referring physicians, right? They are coming from, let's say, Hawaii, right? We have actually a communications with those physicians even before they go back. And we want to make sure that these patients has a close follow-up. And many of time, these hematologists at the referring center, they know them. They just don't have a capacity of providing CAR-T at that place. So we want to make sure that these patients are followed. And a lot of time, I think Daryl mentions like charge stocking, because we have Epic, so we can see them from the other side as well. So we want to make sure that it's very close communication. So we make sure, so I worked in the inpatient settings, and we actually start these communication way before patients transition back to those places, because it's really important. And thank you for the question.
Lots of great questions. We have another one over here.
Hi, I'm the case manager, so thank you for this topic. It's very useful for the case management. Usually I talk to the CAR-T patient for discharge planning. I bring up the no driving for 6 weeks. Usually I tell them 6 weeks. They are so surprised because patient came from a very independent lifestyle, and they know they need a caregiver to help them. And I see the chart on the page 159 say the day 29 plus and beyond, no caregiver needed, but still not able to drive. So I just wonder how much the chance will happen, the late side effect or the ICAMs happen, for how much chance will happen. Thank you.
I can answer that. When you go to the studies, majority of the studies that has been, first of all, there is not a study that you can evidence-based say, it has to be 8 weeks. However, no other study came and prove it that you can do it shorter. So for that reason, for safety reason, majority of the centers unanimously, they say 8 weeks. But I agree with you, because we all are scared of having something happen to the patient. So for the safety, not only for the safety of the patients, the safety of the people that they're gonna end up in a car accident and being affected of that. which was recently came up that if we collect all of our data together and show that there is no evidence showing that if the shoulder started driving can cause trouble, maybe we can reference that point and make it shorter. However, there's none yet. So we stick to the 8 weeks.
We have a question online. For your outpatient CAR T-cell patients, do you have caregivers perform any structured monitoring, e.g. vitals, ICE, et cetera, or primarily educate about signs and symptoms and advise to call/come to ETC if any develop? Generally, we want them to check the fevers and also the signs and symptoms of neurological changes, headache, pain, so things like that. We want them to actually come to our ETC, and some not associated with the ICANS minor symptoms, then they can actually call our triage center, but generally we want them to come to our ETC so that we can evaluate them. So I don't know if that's answered the question.
Chuck, is this beautiful lady back here your wife? I just thought we should acknowledge her and give her a round of applause too. Hi, I guess this question actually is for Chuck's wife, the caregiver. Did you feel prepared with education you received and what you had to do when he was discharged for follow-up?
Well, when they discharged him, when they took him to see if he could walk and what he could do, and he really wanted to get out of the hospital. And I would say, when he came in, he could walk. Why can't he walk now? To me, it was like, what was wrong? But, I saw him through the whole process, and, when he was in the cytochrome, whatever it's called, and he was out of it for so long. And then when he came out and he just wanted to come home, but I didn't really feel prepared, but I felt like he knew, that he was ready. I was hesitant. I go, well, I think you should stay a little bit longer. But, came home, and I'm just glad that I didn't have to do the treatment. I hear you're doing the treatment at home, the CAR Ts at home. I don't think I would have, just seeing him and being there with the nurses and just saying, okay, he's going out of it. You better give him the steroids. And it's like overwhelming. So I can't even, in seeing him not being himself, I can't even imagine doing that at home. It's just, but no, I don't feel like I was prepared. But we made it work. We're just so positive, and he was just so positive. So it was, I think that's half the battle too, is just, he was always positive. Yeah. Thank you.
Anyone else? Well, we talked a lot about, patient education, and, that point right there. I think it can be very overwhelming for patients and their caregivers. I would just ask for, either Athena or May, as every aspect of the CAR T journey is important. One must touch on everything when they're educating the patient and their caregivers. Can you highlight one of the most critical aspects and tell us why?
For me, is actually recognizing that early symptoms, making sure their fevers are reported, even that they feel it might not be fevers, chills, right? Because a lot of time our patients know when they do have fever, they end up being admitted, so they don't want to report. Subtle changes a lot of times might be a difficulty word findings or even a headache that doesn't go away. These are important in the outpatient setting, mainly because we need to treat these urgently. And I'm always nervous when the patients stay locally, meaning their home is close by, so they go home. And it's always at the back of my mind to make sure that they follow, because I want them to be back to our facility where we can manage it properly, as opposed to they end up in the local ER. So that's one point.
I do have the same experience, and I feel like the more we ask them, like those cases that I referred to, because they were in the hospital, they were really bored out of their mind, and every single day I was asking them, "Do you have blurred vision?" And then they were, sarcastically saying, "No, I do not have a blurred vision." And then day after day, the more I asked this, when they really did have it, they realized that, okay, now I really do have the blurred vision. Do you remember you were asking me that? Now I really do. So they realize that this communication is important. I'm relying on them for referring that. And we were able to save those gentlemen, both of them. But however, the other gentleman who omit the symptoms was not able to be saved because they did not get to the hospital fast enough. So the more we communicate and we be candid with our reality, they will work with us because they realize we're a team, and without them, I cannot succeed, and the other way around, and they will work with you. One more thing I'd like to ask is we sometimes do not pay attention to the socioeconomic patients, that they're wealthier, they may be neglected, same as the one that they come with lower income. I had a family that they were very high end, and we all knew that because, due to HIPAA, I'm not going to share more. But during the communications with them, I was asking the wife that the best treatment, at home would be chicken soup. How about if you go home and make a chicken soup? Then she looked at me like, I felt like, oh, maybe she doesn't know how to make chicken soup. I was just giving her the ingredients. And then she looked at me again like, how? And I said like, okay, now we're talking about, you can Google it. There is recipe. She said, where I stay, even though it's a fancy house in Colorado, I mean, in what's the island by our house, that they do not have any pots and pans. And even if I go shopping, well, what am I going to do? So I end up buying the ingredients, not only that, the pots, and I delivered it to her. But, if I didn't have that communication with her, I would not know that. I would assume that, okay, they're well enough and they're going to be fine, but they were not. So, and then sometimes I do have even conversation about finances. It is not my degree, but I feel like, no one else may have enough time. So if I have time, I would brush over that, okay, how about the finances? Are you comfortable? Is there any way we can improve these situations? Because we learn from each other's experience. These are my thoughts.
Another question? Can we get a microphone over there? Sorry. Do you want to raise your hand again? Thanks.
I guess this is not so much a question, but just sharing an experience. When patients go through these treatments and other treatments in preparation to get to this point, a lot of times if something doesn't work right or they're having side effects, they don't want to tell you because they feel like it's their fault. I had a patient who was having a major infusion reaction. He turned beet red and was rigoring, and you could just see it in front of us. And we turned off the infusion, and the patient said, "Oh my gosh, I'm feeling so much better." I go, "Well, that's because we turned it off." But he was so upset that he felt he did something wrong, that he could have stopped it himself physically, but there was nothing he could do to change what happened. Right. So I think it's important just to keep that in mind from the patient perspective, that sometimes they feel like if something doesn't go right, or they're having a side effect, they're having double vision, or they're having a fever, they may not want to tell you because they feel like they did something wrong, or, in your examples, they don't want to come back to the hospital or whatever. But I just thought that was a really interesting perspective from the patient, that, he felt he could have controlled it, but it was not something in his control. So, maybe something in the patient education, we want to just touch on that a little bit, might be helpful.
Great insight.
Thank you for that comment. The case that I share with you guys, that was the case when I see a patient at day hospital every day. He wants to make sure that he's tell me that he doesn't have a fever. He wants to make sure that he's not confused, right? That was the point that he, in his mind, is that I am doing right in a sense, and we have to kind of re-educate and iterate that it's not that anything that you're doing wrong, that there's something to be expected. So thank you so much for sharing that. We do see that.